It's Friday! That's right, it's Friday. This is Dr. Murphy Medical Associates, and our team at coronatestct.com. Today is April 23rd, 2021. And I'm here today to open a can of LaCroix or La Croix, whatever you want to call it. That's right, open up a can today on Murphy's Medical Minute. We will be reviewing one of the keys to get back to normalcy. Today we're going to talk a little bit about the most significant study out of Nature just published this week in regards to veterans, long COVID, and how it can affect you. That's right, on Murphy's Medical Minute today, long COVID, it's real and it's expensive. Oh no, we can't start without the intro, right? We can't start without the intro. So, let's get started. All right, guys, let's get started with the show. All right. Thanks for tuning in today. I really appreciate it. Today's date, again, is the 23rd of April, 2021. I had a little bit of time to review a study accepted in Nature on the 14th of April, 2021, and published just yesterday. That's right, published just yesterday. So we're going to review this truly long-term menace known as COVID-19. That's right, COVID-19, it's not going anywhere. SARS-CoV-2 is significant and it causes death and disability. But first, I would like to sponsor this broadcast through the word of the day. The word of the day today is ultra-crepidarian. Ultra-crepidarian, used as an adjective. Expressing opinions on matters outside the scope of one's knowledge or expertise. That would be like a nurse practitioner evaluating a physician for physician work. That would be like a lawyer evaluating a nurse for nursing work. That would be like a healthcare administrator reviewing a clinician without proper peer review. And in this case, an explanation. Dad, how do we know the universe is expanding? Inquires your 6-year-old. Try answering that without resorting to an ultra-crepidarian trick here or there. Ultra-crepidarian, as a noun, a person who expresses opinions on matters outside the scope of their knowledge or expertise. In medical school, we would call that talking out of one's ass. That's right. Unfortunately, I disagree with the following statement, which lies out here. Most patients are ultra-crepidarians when it comes to medicine. Well, I disagree. I would say that patients know better than a lot of us, and long COVID is showing that day by day. Well, this broadcast really, who's it for? It's for everyone, because everyone's an ultra-crepidarian. Everyone. I want to thank Ellie Murray for some real bravery here. Some real bravery where she published a beautiful article in the Washington Post. She said, I'm an epidemiologist. Now, if you don't know Eleanor Murray, she is an epidemiologist epidemiology. She studies how epidemiologists work. And her work on Twitter, has been breathtakingly fantastic. I followed her the entire time throughout the course of this pandemic. Guess what? Ellie says, I got some stuff wrong, but trying to attack our field and assume ulterior motives for the work that we did is simply wildly unfair. And that's right. I'm here to tell you right now, judging people who answered the call, judging the people who answered the call, trying to call them fraudulent or scammers or control freaks or evil pirates, that's crazy. That is just crazy. Here's the problem. We don't have all the data, so we can't judge everyone. Second problem, it's too easy to judge each other's ill intent. It's too easy to judge each other's ill intent. And frankly, I remain deeply concerned that one of the problems we have these days, and why a lot of the doctors didn't answer the call, is because they knew that this would happen. They knew that Monday morning quarterbacks, lawyers, regulators, armchair Twitterati, news journalists would sit there and point out how bad everyone else is without recognizing the plague on their house, especially if they didn't volunteer to test in a line, if they didn't volunteer to work 80 hours a week, if they didn't volunteer to give vaccines out. I think we got a little bit of hubris, and that's the problem. Hubris versus humility. How are we going to get out of it? How are we going to get out of this entire thing? And frankly, I think we're going to need some heavy-duty science, some heavy-duty social services, and I think the future really is going to be naturalized health systems. I will tell you right now that only those in the trenches should be judging those in the trenches, not those getting high with the Frenches. That's right. So even the White House COVID-19 response team on Twitter recognizes that they do not understand the risk of developing long COVID after what they call a breakthrough case. But they do acknowledge long COVID. What's a breakthrough case? That's someone who would have vaccination. Our hope is that vaccination, remember, vaccination is one of the keys, not the only key to getting back to normalcy. And despite what Governor Cuomo said, where he said, this all ends in 12 to 18 months when vaccines are there and you're 100% safe. Well, no one's going to be 100% safe. And in this case, who is safe from long COVID? I can't tell you who's going to be safe from long COVID. And to blow off a patient who had a mild infection, that's just bad medicine. Not testing them for laboratories, you're trying to let them die. But hey, what do I know? I'm not an independent consultant. I'm just a doctor in the trenches. And I'll tell you right now that the problem here is a lie. It's not the big lie. The big lie is that kids don't get COVID. It's one of our littler lies. The littler lie is that COVID-19 is just a little infection. You get a little cough and it'll go away. Most people do just fine, despite the fact that about 10% of people who had COVID end up in the hospital, and about 1% of them end up in the ICU. And in the earlier statistics, most of those people ended up dying. So that's a pretty significant death rate for just a mild infection. Another problem that we have is when people were discharged out, and Daniel Griffin says they were clapped out of the hospital. And they were. Stanford Hospital played Here Comes the Sun. They played all sorts of music to the champions that congrats, you got out of the hospital. Well, congrats, you got out of the hospital, but now you've got a complicated, horrible course. And we used to just think, and especially at the big health centers like Mount Sinai where I trained, that long COVID really was just going to be those patients that were hospitalized. Boy, were they wrong. Boy, were they wrong. I'm here to tell you right now, 13 to 35% of all patients that got COVID, they have long COVID. How do I know? I'm dealing with it every day. As our testing numbers go down, our telemedicine visits for long COVID go up. That's right, they go up. So long COVID and death happen even after mild infection. And this study that we're going to review today shows all of that. Again, this just goes back to hubris. It goes back to hubris. You know, I'll tell you right now, I'm blown away by the public health people and how hard they're working. But I'm also blown away by those not in public health, but in governmental service that are taking pot shots at the clinicians and at the public health workers. And frankly, it blows me away. And I'll tell you why. A practice like mine, like Murphy Medical Associates, we went into inner city underserved communities. We were the first ones really to do testing in the inner cities before federally qualified health centers had money. And we didn't have money either. We were putting this stuff on our credit cards because the insurance companies weren't paying us. But we jumped into line. We answered the call right away. Downtown Stamford, then Bridgeport and New Haven and Dwight. Attacking us resulted in the loss of testing in underserved communities at a significant rate, even with the federally qualified health centers delivering that care. Thousands of people suffered. Thousands. Why? Because of hubris. Because of hubris. Because of ultra-crepidarianism. That's right. So I think we all need to be humble. We need to take care of each other. And I think that the White House is right. We do know that long COVID can follow even mild cases of COVID-19. That's right. People who have symptoms for a day or two, they go along for a month, maybe 8 days, maybe 9 days without symptoms. Does that mean you shouldn't test their labs? No. I mean, if you're an ultra-crepidarian, you could say don't test their labs, but I wouldn't because I've seen bad stuff happen. And the White House COVID-19 response team indicates the same thing as well. That's right. The devastation from this pandemic is only truly going to be known about 4 to 5 years out. And insurers refusing payments for this care in an outdated system is not going to work. It's not going to work. It has to be fixed. So, on to the study. Who are we talking about? A soldier's song. We'll sing a soldier's song, right? That's for my Irish friends out there. It's for my Irish friends out there. I want to make a very, very important point here. The Veterans Administration databases were queried in this study published yesterday in Nature. A study published in Nature by Ziyad Al-Aly and Benjamin Bowe. B-O-W-E. Maybe Bow, like Bowie, but I would call it Bow. So this excellent data review investigated a cohort of 73,435 users of the Veterans Health Administration who survived past the first 30 days of COVID. That's right, and they weren't hospitalized. So these are mild cases. In addition, they also reviewed hospitalized cases. And they reviewed, in addition to that, 4,990,835 users who did not have COVID-19 and who are not hospitalized. So that's a pretty big control group that they have there. They did median follow-ups. They watch them for 130 days. And they have some very, very surprising statistics that we're going to review today. First, the most important part of this is that they were studying the post-acute sequelae of COVID-19, otherwise known as all the crap that happens after you get infected with COVID-19. From day 1, day 10, day 30, day 200. Well, in their case, day 130. I can tell you right now, we're following people that had COVID in the first wave. They've got stuff going on. They have stuff going on. And I'll tell you, based on our clinical experience, it's probably around 15%. Probably around 15% of them have real stuff going on. Sorry, I gotta shut the old phone off, make sure we don't get the old ringtones again. All right, so what are we gonna find? We're gonna find that 59% increased risk of death 6 months out. What? If you had COVID-19, you are 60% more likely to have an increased risk, your increased risk of death 6 months out after COVID, actuarially, is 59% increased relative to the background noise of other veterans who did not have COVID-19. And I say that here, as you can see here in the military.com news site, which I follow. My father's a retired Army colonel. My brother is overseas now serving. He's in communications. I was a naval midshipman. Probably could have been a better sailor. So here's the deal. Here's the deal. These veterans had an increased risk of death 6 months out. So mild COVID increases your risk of death. It isn't just, oh, I got COVID for a couple of days. Bull crap. Bull crap. Anyone who says that right now is an ultra-crepidarian. Straight up, ultra-crepidarian. There's more than enough evidence for long COVID out there. To deny these patients that they have long COVID is, honestly, it's disgusting. It's disgusting. The problem is that COVID's everywhere. It affects everything. And I think that the solution is going to be some sort of black lung fund. You know, we did the 9/11 thing. That was 3,000, 4,000, maybe 20,000 people, maximum 100,000 people affected. How many hundreds of thousands of people have died from COVID? How many millions have been infected? So the problem is it's everywhere. And I think we're going to have to set up a system through Medicare, very similar to dialysis, or a black lung fund. We've got to figure out what's going on here. And if you leave long COVID untreated and with the wrong medications, it leads to an increased risk of death, even 6 months out. And by not checking laboratories in patients who have long COVID, or in patients who just had COVID, or in patients who have COVID, you're an ultracrepidarian. That's right. If you're a physician blowing off long COVID, if you're blowing off short COVID, if you're blowing off getting laboratories to evaluate the prognosis of someone with COVID, you're putting lives at risk. You're putting lives at risk. And I can't stand by that. And I can't stand by anyone at my state who would say such dangerous, outrageous things. So what else did they find? Well, they found that these patients in the Veteran Administration database had significantly increased need for medications and increased medications. Those medications included pain meds, opiates, as well as non-opiate containing pain medications and anti-cough medications. They had anticoagulants. They had lung medication, breathing medications. And one of the surprises that I found in this data was that they needed iron. That's right, some of these people had iron defects from COVID. In addition to that, another surprise for me, they had dyslipidemia. Now, maybe that wasn't a crazy surprise to me because part of the laboratories that we tested included thyroid panels. Now, one of the things missing here in the studies, we'll go over this Nature study in a little bit. One of the things missing is a full deep dive into the endocrine system for the VA system. I'll tell you why that is in a little bit. But with abnormal thyroid, you could have abnormal lipids. I'm trying otherwise to think through the entire system metabolically to understand, and perhaps it's also insulin resistance and increased risk of diabetes. Another thing that was not fully vetted with this study. However, the important part about the incident sequela in this is it's not just the respiratory system. It's the nervous system. It's neurocognitive. It's mental health disorders. It's metabolic disorders. It's cardiovascular disorders. It's GI system disorders. It's malaise. It's fatigue. Yes, common diagnoses that we build for that people decided to call us scammers. Guess what? People get fatigue, musculoskeletal pain. It's anemia. It's anemia. The increased use of these medications, the pain medications, the antidepressants, the anxiolytics, the antihypertensives, are significant. The spend that's going to happen for all of these patients who have sequela from COVID is going to be massive. The damage is everywhere, and it's not just money. The disease that COVID causes and the disability, which I think is so amazing here. The hazard ratio on having respiratory signs and symptoms up to 6 months out, 28-fold. It's a 28-fold increase in your hazard ratio. To get high blood pressure, 15-fold. Hypertension is one of the biggest things that causes kidney disease, and we'll go over that little expenditure very soon. We have sleep-wake disorders. We have nervous system signs and symptoms. I was just on a telemedicine visit with a really good physician assistant who had COVID pretty early on. And I'm going to tell you the story about this patient. So this patient went and got tested, not at one of our centers. This patient went and got tested at a big health system. Went and got tested at a big health system and was never called for their results. Never called. And in fact, there was an alert on their phone that the person had a positive result. Why? Because the results were delivered automatically through their MyChart app, right? Through their MyChart app, which is epic. And so I'll tell you right now, if you're spending money, that's a fantastic scalable system. If you're a patient, that's like the diagnostic machine in Idiocracy. No, don't put that one there, put that one. It's insane. We can't scale medicine. We can't scale medicine, and we need to stop trying to scale medicine because it's going to kill people. The push to lower costs is killing people. We have to have someone who's not an ultra-crepidarian interjecting and explaining how medicine works. Because we can't have Monday morning quarterbacking with COVID-19. It's going to happen. I already see it. I already deal with it at the state level. I deal with it at the insurance company level. We'll talk about that in a little bit too. So here's what we found with the Veteran Administration databases. Pulm, CV, hormonal, neuro, GI, lipids, psych, musculoskeletal system issues. I can tell you what else I found. I found genitourinary issues. I found kidney issues. I found skin issues. I found bone issues. Why? Because we looked. We looked. Also, probably the biggest one is the thrombotic risks, the clot risks. Some of the surprises I found were the esophageal disorders. I was not surprised when we saw some of the hypertension, hypotension issues going on here, or the funny heartbeats. It's no surprise with that at all. And in fact, a lot of the long COVID patients will tell you that they get labeled in the what we call POTS syndrome, postural orthostatic tachycardia syndrome. It's not quite exactly what's going on here with COVID, with long COVID. We don't quite know it per se. Now, what you need to remember is long COVID is not just one disease. It's multiple diseases, and the sequelae of a SARS-CoV-2 mild infection are serious. There are serious sequelae, and for anyone to be glib and just say, oh, it wasn't on up to date, so it's not real, again, that's ultra-crepidarian. You're talking out of your ass. You Googled research that was wrong and out of date, not up to date. And that's one of the problems with point-of-care decision-making tools these days, is that they're not up to date. And even if they are up to date, they're not properly updated. You know, all you got to do is look at the up-to-date articles for care of people post-COVID-19. One of the articles said laboratories aren't useful. Get out of here. Get out of here. We're going to go over to the labs in a couple of seconds. But you can see here, take a look. All of this sequelae, long COVID sequelae are everywhere. They're everywhere. And the future is expensive care, not just on our veterans where the study was carried out, but on everyone, on everyone. The laboratory diagnostics and the other studies that are going to happen and come out right now are going to indicate that Dr. Murphy Medical Associates, and our team at coronatestct.com were prescient with our response. Let me tell you why. Because we read journal articles, because we looked at disease reports and case reports from China, from Korea, and from Italy. We did our homework. We did our homework. And I will tell you, if anyone's going to go after Ellie, they better do their homework. Because you are not going to have a brighter or more diligent epidemiologist who's willing to acknowledge her shortcomings and her mistakes. She's a model for us all. And I'll tell you, we made mistakes too. But if you're going to shoot arrows from your office space or from your Zoom room, then you better be prepared. You better be prepared, because we did our homework. This Nature article demonstrates people who have COVID need labs. People who have COVID need early diagnosis of all of the sequelae. And that sequelae show up even 6 months out. And the costs to our country are going to be expensive. Now is not the time to try and cheap out. Now is not the time to try and cut corners and save costs, because we're early in the sequelae. So hopefully we can treat this stuff and prevent it from getting way worse. What? How do we do that? It's called lab tests. You know, one of the most important things about this Nature study, just published yesterday, was that they analyzed 38 different laboratory measurements. There's 38 different labs. Wait a second, why'd you order so many labs when the patient had COVID? Well, I'll tell you, we ordered these labs plus more. And in fact, I'll tell you right now, the VA systems have budgets. And unlike the insurance companies with record profits, they can only spend so much. They can only send so much. And because of that, they could only search so much. We're going to find more studies that are going to show hormones were off, the inflammatory cascade, looking at IL-6, looking at IL-10, looking at RANTES, looking at VEGF, looking at a series of immunodysregulators, as well as things like tumor markers, they're going to find that they're all off. They're going to find that they're all off. And it's going to indicate that these abnormalities led to poor prognoses. How do we know that? I can tell you right now. Low vitamin D in patients is a higher increased risk of getting COVID. Low vitamin D is an increased risk of and a poor prognostic factor for this infection. It's expensive. It's an expensive test. But guess what? The insurance companies had record profits. Record profits. So you're telling me rather than pay their CEOs and execs bonuses, they can't pay for proper health care. The only reason insurance companies exist is to pay for the proper health care. They take the money from the employees, they take the money from the employers, and they pay it for health care. If they don't, we got a problem. So here's the problem. They found 62 different abnormalities in these 38 labs. Too high, too low, or anything in between. Really, what I was surprised about with this study is as I said before, there are so many other laboratories that need to be used to evaluate the patient with COVID and post-COVID sequelae, known as long COVID. And these lab measurements are so much more than just these. But I can tell you, we did these labs, and they found abnormalities in these labs. Why didn't they look at the other labs? It's money. Running an immunoassay laboratory is expensive. I can tell you right now myself. When we started testing people in our secure, our BSL secure labs, where we had phlebotomists, nurse practitioners, PAs, and nurses, full Tyvek suited out with N95s on, face shields, double gloved, trying to perform phlebotomy, which, by the way, is a difficult phlebotomy. I don't care what anyone else says. They can try and jump in the suit and do it, and then do it 50 times in a day. What we found was we were spending a lot of money on reagents, thousands upon thousands of dollars, and insurance companies didn't pay us. Because of this, the VA did not look at immunoassay labs. Why? Because those other labs are very expensive to run. So they looked at what they had. This was a study that was limited in scope. As we expand the scope, we're going to find that there's more damage than just these. Way more damage. The outcome here is much worse than any of us have imagined. Much worse. And it's going to continue. We look at the increased risk of people who had sequelae who were not hospitalized. These are patients who went 30 days without hospitalization with their COVID-19. And what do we find in them through their long course over the next 120 days? Massive, massive hazard ratios. 3 times the risk of pulmonary emboli. That'll kill you. And in fact, one of the patients that we're working with the state on had real risk there. But if you listen to the independent consultant, we would have missed that risk. Why? Because we shouldn't do labs in patients who had COVID, even though they don't have symptoms. I respect your right to question me. I don't respect your right to be ultra-crepidarian. Do the homework. The risk is significant of clots. The risk is significant of DVTs. The risk is significant of life-threatening blood clots in your lungs. That's why we tried to get our CT scan machine back in the very beginning of this, is we were worried about blood clots. We were also worried about alternative diagnoses. We were also worried about being able to diagnose someone with COVID because we knew the PCR labs would be overwhelmed. We knew in China they were diagnosing people with CT scan. And here we see pulmonary outcomes, respiratory tract issues. We see issues with endocrine systems, diabetes, muscle pains, and I could tell you, tremors, infections, GI disorders, esophageal disorders. This disease messes with everything. Everything. So when someone says, why did you do labs? Why did you do all of these labs? Because the disease messes with everything. Well, why didn't you wait till they just had symptoms? We're going to go over what a fool would do here and cost governments millions of dollars more by trying to cheap out on a couple of $100 worth of labs. More diseases, more surprises. The big surprises that I found was the dysphagia which was either neurologic or it was due to esophageal dysmotility. There were pressure ulcers, meaning people really couldn't move around. They had greatly reduced mobility, and lipid disturbance. Like I said, the lipid disturbance really needs to be, it needs to be teased out. COVID affects all systems, so you need labs for every system. How do you know which system is going to be affected? You don't. So you test. Not just COVID tests, but all the tests. And the future, unfortunately, governments are going to need to prepare for this. This is going to be more costly than dialysis and far worse, like I said, than any of us have imagined. If you're affected with COVID-19, you can see if you're positive, you have increased risk of disease. If you are hospitalized, you have even more risk of disease. And if you were in the ICU and made it out, you have even more risk. But just because you were in the ICU and you have this sky-high risk doesn't mean that you didn't have risk with mild COVID. You did. And the study from Nature definitively shows this. Now remember, this study and these excess burdens, these hazard ratios are elevated. They're elevated with who? A group of veterans. Veterans are tough people that don't complain about stuff very often. And very, very few of them will go to the doctor unless they absolutely have to. How is this going to affect us? How's this going to affect us? Let me tell you how it's going to affect us. Right now, pre-COVID, as of 2019, 37 million Americans now have chronic kidney disease. What's chronic kidney disease? So I have to be cautious here with the chronic kidney disease. It's very important. It's very important you understand this. Insurance companies are getting sued now by the federal government for cooking the books. And I want to explain this to you. They're getting in trouble for cooking the books. And let me tell you the insurance company scam that they have. The scam is this. They request through Ciox or one of these other companies, a soap note company, that says, hey, doc, if you just fill out this note, we'll pay you $30 to $50 to $100 for each of your patients. These patients are managed Medicare patients. Why does this matter? Because the federal government gives a certain amount of money for each disease to every insurance company that has managed Medicare. And then those insurance companies pay for the costs of the managed Medicare patient's care. Do they pay? No, they're an insurance company. They stiff the doctors. They pocket the governmental money. But even more important than that, you know what they do? They cook the books. They look at a creatinine level, a single creatinine level, and will say that the patient has chronic kidney disease. They'll upcode it. They'll tell the insurance company they'll upcode it, and the insurance company will then ask for more money from Uncle Sam, which really, let's not fool each other. That money is coming out of our tax dollars. That money's coming out of our tax dollars. So the insurance companies, again, will pull the citizens' tax dollars out. I only caution you, as I say, 37 million Americans have been estimated to have chronic kidney disease. Chronic kidney disease leads to renal failure. Renal failure, end-stage renal disease, leads to dialysis. Now, Medicare pays for all dialysis in the United States. All dialysis patients in the United States, all of them, on average, $90,000 per year is spent on that patient every year that they're alive. Every year that they're alive. If you really want to know this, the mortality at 5 years of dialysis is 50%. So half of those people die at 5 years. So what is that? That's $500,000 spent on that patient just for dialysis alone, not mentioning all the times they're in and out of the hospital for their bleeding and their electrolyte disturbances. And end-stage renal disease patients have heart attacks. They have strokes. So there's a lot more to this care for the end-stage renal disease patient than just the dialysis. Dialysis truly is the single-payer system in the United States. And how much of all Medicare spending does dialysis take? 20%. One of every $5 spent on healthcare is for dialysis. One out of every $5 of the federal budget for Medicare is spent on dialysis. That's great. How do we prevent people from going on dialysis? Let me tell you. You ready? You ready? Because it's going to sound familiar. Lab tests. Yeah, stop. Stop. You do lab tests. We do lab tests? Yes, we do lab tests on asymptomatic patients. Why? Because the symptoms sneak up on you. 40% of people that go into end-stage renal disease didn't have any symptoms until their kidneys stopped working. That's right. They didn't have symptoms until their kidneys stopped working. We're going to get the same thing with COVID, people. We're going to get the same thing. Those people that drop dead in the streets from pulmonary emboli, you think the big clots are the issue? It's the microemboli. It's the small clots. It's one of the reasons why with our COVID-19 patients, we actually ultrasounded their renal arteries. We looked at their renal vasculature for resistance to look for microclots. Why? Because we knew those patients with COVID-19 would become kidney patients. And we wanted to catch them early and treat them to prevent kidney disease. Why? I just told you. Dialysis is a massive drain on the federal budget. It is 20% of all Medicare spending. Cautionary tale number 2. Costs go up when you allow monopolies to happen. And this is very important. I want everyone to remember this. As we see big institutional healthcare centers developing long COVID clinics, I want everyone to remember who is best suited to treat long COVID. It's the primary care physician. The primary care physician. Unfortunately, the primary care physician can't do dialysis in the United States. And I know a lot of renal doctors that would run dialysis centers, but their reimbursements went down and down and down. It kept getting cut. And so they sold their centers. Who'd they sell them to? That's right. DaVita and Fresenius. There are more dialysis centers in the United States than there are Burger King restaurants. I just want you to think through that, right? Because Burger King causes diabetes. Diabetes leads to kidney disease, which leads to dialysis. There are more dialysis centers than there are Burger Kings in the United States. And DaVita and Fresenius control 80% of the market. 80% of the market. It sounds really similar to the top 5 insurance companies that we have in the United States. I'm not forgetting you, Molina, sending me a penny for each of my COVID tests. You think that's cute, dude? Keep going. We'll sue you too. The problem with costs going up in a single payer model is the near monopoly provider. The near monopoly provider. Big groups here are buying the small providers and costs are going up. So if we're going to centralize post-COVID care, why would we expect anything different? Post-COVID care, syndrome care needs to be brought down at a community-based level. But if we allow it to be monopolized, we're going to have a spiraling budget deficit. There's no doubt. Don't believe me? Take a look. When DaVita and Fresenius acquired the dialysis centers, the billing changed. It spiked. It went up 10%. Bong. Straight up. Straight up. That's right. Medicare was paying billions upon billions. And again, to remind you, 20% of all Medicare spending, $1 in $5, is going to 80 cents of those $1 in $5, maybe more, is going to 2 companies, DaVita and Fresenius. If we allow long COVID care to be centralized this way, the same thing's going to happen. And it's crystal clear to me, I don't know about you, but I can see it because I'm not an ultra-crepidarian. I'm in the healthcare system deeply. I run a multi-specialty medical practice. I serve as a consultant. I'm a laboratory director. And we brought the first COVID testing on the East Coast, and I've been fighting for the entire last 13 months to flatten the curve and prevent disease. But I can tell you over the last years of running my medical practice that it's crystal clear that the arms race between hospital systems and insurers to buy doctors and replace doctors is not resulting in cheaper care. It's resulting in bigger bottom lines at the risk of patient care. So how can we fix it? How can we really fix this problem that we have here? What's the problem? Post-COVID sequelae, long COVID, or long haulers, or long COVID kids. And that's probably the worst one. Don't get me started. The kids, oh God, the kids don't deserve any of this. They're our future, and they are our kids suffering with long COVID. So step one in this fix is to admit the problem by believing the patient. Patient has symptoms, it's not psych. Psych should be the last part of your diagnosis at the very end. Sure, they may have microemboli that are causing them to have psychological disturbances, but you better evaluate their physiology and their medical conditions before you blow this off as psych. Second, step two, lab test. Test, including lab tests that maybe you don't understand, but physicians in the know do. Right? Physicians in the know do. And if they don't understand, well, then they should read about it before they start getting all ultra-crepidarian. You should read about it before they get ultra-crepidarian. Read the studies. It's crystal clear. Laboratories help us pick up post-infectious problems, both early, during the disease, in the first few weeks of the disease, and late, even up to 6 months after the disease. Step three, who's going to pay for all of this care? Right now, the Federal CARES Act says the following. COVID testing and COVID care related to this care, whether you have had COVID or were exposed to COVID, must, the word would be shall be paid for without medical management through prior auth, without medical management through denials, without medical management through record requests, without out-of-network or in-network. It doesn't matter. As an insurer, you have to pay. Don't delay. The problem is so many doctors stayed on the sidelines because they were worried they weren't going to get paid. And I can tell you right now, they're smarter than me. Ellie Murray, you made your mistakes, I made mine. My mistake was trusting that insurance companies would follow federal law. They didn't, and they continue not to follow federal law on a daily basis. Or they play little games like Molina, sending me 1 penny as payment for COVID-19 testing. A penny. That's completely disrespectful, and it's not just once that they've done it. They've done it over 30 times. It's not funny, guys. Not funny at all. Pay your bills. We need to hold insurance companies liable for the insured patient's costs, so that way patients don't go bankrupt. So that way doctors don't go bankrupt. They can care for their patients. And we need to backstop that payment with a public health plan. You know, one of the most important things that I'll tell you right now, Governor Lamont, I love you, man. I had a talk with you. You are doing a great job in Connecticut. People, oh, okay, here come the arrows from the right. Enjoy, right? I can say something about Governor Cuomo and then I'll get the arrows from the left. I'm going to tell you this right now. I love all, I serve all. Governor Lamont is trying to create a public plan for the state of Connecticut that is desperately needed. What was the insurance company's response? Well, Don Corleone up there at Cigna says, if you create your plan, we'll pull our jobs out of your state because we can work remotely and then you go bankrupt. The irony in that is rich, especially as the insurance companies continue to squeeze small businesses with higher premiums while stiffing physicians and forcing consolidation at the health system level, resulting in massively higher costs. So step 5, let's regulate this insurance racket properly. And let's remember what it really is. These insurance companies are finance companies that take money from employers and employees, and rather than pay it to healthcare, they take it as profits. That's right, they take the premium as profit. Lastly, we need to understand what COVID-19, post-COVID syndrome, long hauler care, long COVID care is. And we do that by pouring money into research. And I'm here to tell you right now, President Biden is doing a good job with it, but we have to make sure that that money gets spread evenly throughout all aspects of research. And we cannot, I repeat, we cannot silence their debate. We have to be allowed civil discourse. Otherwise, we are never getting out this pandemic. You know, I want to read this here. Just bear with me a couple of seconds. As I said about Connecticut, right? There are doctors all over the place that are going to be suing Cigna for their chicanery going on right now. And as one New Jersey laboratory says, Cigna can't shake the virus-covered suit, right? They moved to dismiss again. They responded. They moved to dismiss against us. And I can't comment on our legal stuff. I leave that to our lawyers. MedPage. I know you wanted a comment today. Here's the comment. Go talk to our attorneys. Or talk to Kevin Lembo. They're trying to create a public option in Connecticut. And what happens? I told you what happened. So Kevin Lembo says, when will enough be enough? The corporations represented in this letter, finance companies, many of whom enjoy state contracts supported by taxpayers, have brought in record profits during a global pandemic. Record profits. The hospitals lost money. Private practices lost money. These 5 executives combined received over $100 million in compensation last year. $100 million went to 5 people, 5 CEOs of these finance companies. How much money do they need before they'll support making healthcare affordable for working people? No one is a bigger criminal at stealing employee dollars than these insurance companies. The wishes of these 5 multimillionaires don't outweigh the needs of other residents of Connecticut, the overwhelming majority of whom know healthcare is not affordable. And I just went through why healthcare is not affordable. And they want their government to do something about it. Most importantly, over the years, an aside before I finish this up, as an aside, the insurance companies hide in the shadows. Let me rephrase it. The finance brothers who pretend to pay for healthcare have hidden in the shadows for years. Gag clauses where you can't see what they're charging or what they're paying everyone else, splitting and fighting healthcare providers, pitting them against each other. These Corleone tactics are not acceptable. And finally, Kevin Lembo says it. I'm grateful that the insurance industry is finally stating the public threats that they've been making behind closed doors to lawmakers for years. Lawmakers need to step up here. Focus the attack where it needs to go, not on the healthcare providers that are sacrificing on a daily basis. It makes this choice stark. Are legislators going to serve their constituents, or do 5 corporations determine what becomes laws in our state? Insurance financing, insurance healthcare lobbying is massive. Kevin Lembo has faith that they will make the right decision and help bring about the change that our constituents are demanding. Connecticut needs to recover. New York needs to recover. New Jersey needs to recover. The United States needs to recover from this pandemic, and the companies that made record profits need to hold up to their social contract. Long COVID is real. Despite what craven insurance companies and crony politicos have to say, it's real and it needs to be paid for. So how do we get out? How do we get out? I'll tell everyone again. Dr. Murphy's 6 keys to getting out to normalcy. Prophylactic medications prevent the infection. Abortive medications treat the medication quickly. Diagnostics to identify prognosis. You're sick? Let's test you and let's see whether or not you're going to get even sicker. 4, diagnostics to diagnose long COVID, and that's part of what we see here in this Nature study that was published yesterday. People who even have mild COVID can get long COVID, and in fact more often do. We need proper vaccination. What does that mean? We need full approval of these vaccines, not this half-handed EUA thing. I'm happy with our BioFire machines. They are the only FDA-approved machine to test for COVID, fully approved. And lastly, 6, we need to be able to do event testing on site. Event testing on site. It's great that you can go buy 2 Binax Now cards for 25 or 30 bucks in Walgreens. But we need on-site event testing, antigen testing. I'm coming in line with Michael Mina. I am, buddy. Congratulations. I'm a skeptic and you got me. We need to do these antigen tests like the Major League Baseball has. We roll our vans down to Yankee Stadium and we test before you go in the stadium. In 15 minutes, we know whether you should be in the stadium or not. These are the type of tests we need to do. Patients are exhausted. They want back to normalcy. And I tell you what, they don't trust the politicians. They definitely don't trust the insurance companies. And we desperately need a path out. Here's the takeaway. Long COVID costs will be enormous. Be prepared. Refusal of the existence of long COVID only delays the truth. And I believe that our program of early detection of complications with lots of quote-unquote unrelated labs that didn't show up in an up-to-date article saved lives. Our mortality rate in the first wave was 0%. We continue to take care of our long COVID patients. We treated those with anticoagulation that were at risk of pulmonary emboli. We saved lives. In this Nature study, again, don't be ultra-crepidarian. There were missing labs noted. I told you about them, and I believe that's because of budgetary constraints. But even then, the study showed that 6 months out, if you had COVID, you're 59% higher risk of dying. The morbidity here with extended studies is going to skyrocket. And we have to have a plan to pay for this care. We have to have a plan to pay. People can't work for free. We have to have a plan to pay. If we don't have a plan to pay, I don't know what we're going to do. I don't know what we're going to do. So, I ran an hour today. That's remarkable. So I want to tell you a couple of things, and I appreciate you waiting this long for this super long Murphy's Medical 52 minutes and 45 seconds. Thank you. I appreciate you hanging in this long. It's worth it. I want to tell you a couple of things that are going on right now that I'm excited about. We have our long COVID clinics up and running, and I'm very happy with them. We are doing mobile testing in the tri-state area at events to help be part of the solution, part of the keys. We do this as we continue to get shots and arrows by insurance companies refusing to pay us. Why? Because it's the right thing to do. It's the right thing to do to take care of patients and try and find a way to build a bridge back to the new normal. And the new normal in this case is skyrocketing healthcare costs for those patients that were affected with COVID-19. Trying to bankrupt these patients is simply unfair. And because of that, we need to have a federal healthcare system that's going to hold record profitable finance companies called insurance companies accountable. The question is whether the government has the willingness to do it despite the Scrooge McDuck dollars sent by the lobbyists to political campaigns. Kevin Lembo's right. Do our politicians have the intestinal fortitude to do what's right, to take care of these constituents, these millions upon millions of patients who had COVID-19 and who will have long COVID sequelae? This is Dr. Murphy Medical Associates and our team at coronatestct.com. I really want to thank all of you today. Today is April 23rd, 2021. I'm going to bring it out again. What's the bear mean? We protect our own. And if you're watching Murphy's Medical Minute, you are part of our own. You are part of the family. We appreciate you. You just watched Murphy's Medical Minute.
With